Hello everyone, welcome to Surgical Insights with Dr.Deepz. Today we will discuss one of the most critical emergency medicine and surgeries, cardiogenic shocks. This is the first slide. We would be defining about cardiogenic shock. It is a state of inadequate tissue perfusion caused by failure of the heart to pump sufficient blood. Okay, despite having adequate blood volume, the falling myocardium cannot maintain the cardiac output without rapid recognition and treatment. It carries a very high mortality. So, in simple, cardiogenic shock is a state of inadequate tissue perfusion due to its failure of the heart to pump effectively despite adequate circulating blood volume. Okay, we would be going to next. In next slide, this is about the cardiogenic shock common causes. Most common cause is acute myocardial infarction and especially involving the left ventricle, and other causes may include severe cardiomyopathy, okay, and myocarditis, valvular heart disease, and life-threatening arrhythmia, and mechanical complications such as ventricular septal defects or papillary muscle ruptures. So in this slide, we will be discussing about the hemodynamic changes. Most likely in examination point of view, they will give you the parameter whether the cardiac output is decreased, blood pressure is decreased, and systemic vascular resistance is increased. What they will give you the blood parameter and tell you to identify. This is the way they ask you the shock interpretation. In cardiogenic shock, the cardiac output falls because of impaired ventricular contraction. As compensation, systemic vascular resistance increase while pulmonary capillary wedge pressure and central venous pressure rises due to blood backing up into the lungs and venous circulation. These hemodynamic changes will help to distinguish cardiogenic shock from other shock states. In cardiogenic shock, cardiac output usually drops. Okay, and next is blood pressure also usually drops, and rest of all increases like systemic vascular resistance increases. I have also provided the reason for cardiac output because failure of heart to pump eject adequate blood. Okay, similarly we read another thing. uh, we read also hypovolemic shock in previous session. Cardiac output still decreases, you can see here, decrease cardiac output. I will be discussing in upcoming slides. Okay, and okay, cardiac output actually decreases due to failure of heart pump to eject the adequate blood. Okay, to eject the adequate blood. And in blood pressure, it decreases because reduced cardiac output leads to decrease arterial pressure. Decrease arterial pressure. And next is systemic vascular resistance. Systemic vascular resistance compensatory vasoconstriction to maintain the perfusion of vital organ. Perfusion of vital organ. This is important. So compensatory vasoconstriction. Heart rate is usually increased due to sympathetic activation in response to low cardiac output. Okay, so heart rate increase. Okay, and next is pulmonary wedge capillary pressure also increase because blood backs up into pulmonary circulation due to left ventricular failure. Okay, and central venous pressure also increases as increase right arterial pressure due to poor blood flow. So in last slide before the problem, I have mentioned about the shortcuts. We will be discussing about the shortcuts, how to identify, not to worry about any other thing. Then clinical features, we can see hypotension, hypotension in both cardiogenic shock as well as hypovolemic shock. Tachycardia we can see, which is due to compensatory increase in heart rate, similar feature. And next is pulmonary edema, maybe due to dyspnea, orthopnea, and basal crepitation due to raised left ventricular filling pressures. Okay, raised JVP. Okay, raised JVP means jugular venous pressure that can be seen due to elevated jugular venous pressure due to increased right arterial pressure. Due to increased right arterial pressure, you have to know. and the patient usually present with cold, clammy and extremities, okay, and peripheral vasoconstriction or poor perfusion. This may be also due to other reason like for instance, there is a scenario with uh, axillary this thing blockage, axillary artery blockage, and there is also a similarities with DVT. So cold and clammy extremities can be seen in both of them. Okay. Next is altered mental status, confusion, restlessness, and decreased level of consciousness due to cerebral hypoperfusion, And metabolic acidosis is seen in most of the state due to tissue hypoperfusion and lactic acidosis. We already discussed about metabolic acidosis in hypovolemia because almost the same causes you will be presenting. That is because of low blood supply, and this is because of failure of valve to pump the blood. This is the key differences between hypovolemia and cardiogenic shock. Okay, and key point to be noted: low cardiac output leads to hypotension, and poor tissue perfusion and signs of fluid congestion also seen. Let me check it. Okay, here investigation of choice, ECG. You can see ECG mainly ischemic changes or evidence of myocardial infarction. Everyone knows about myocardial infarction. It may be with ST depression, okay, ST segment depression or ST segment elevation, also ischemic injury, so cardiogenic shock, okay. And cardiac enzymes like troponin T and troponin I and cardiokinase MB, okay. So to detect myocardial injury elevated in myocardial infarction, okay, and also LDH and rare cases seen, and LDH may be decrease and death of LDH seen in pulmonary artery, okay, traveling through pulmonary artery. And next is arterial blood gas. You can see metabolic acidosis as we discussed in previous slide. To evaluate oxygenation and ventilation, metabolic acidosis raised lactate, and next is indicates poor tissue perfusion, okay, poor oxygen supply, one of the reason. And chest x-ray, you can see pneumothorax or consolidation, you can see, and edema, pulmonary edema, you can see. I will be teaching separately when the systemic surgery topic will be okay. And next is serum lactate. You can see elevated in tissue hypoperfusion and anaerobic metabolism, and routine blood test. Okay, full blood count is seen, and UND, which is urinary and examination, glucose and liver function test, coagulation profile like ATPT, PTT, PT, all those interpretation to access the end organ function and complication. You have to know this. I will be teaching you in deep about platelet and thrombin interpretation in upcoming session. So as of now, you have to memorize just this. So these are the differentiation between cardiogenic and hypovolemic shock. We already discussed about this in previous topic, but still I have to enhance more with clinical reasoning, with pathological reasoning I have produced. So cardiac output is decreased in both the state. Reason in cardiogenic shock it is pump failure, and in hypovolemic shock it is reduced preload. Next is first, let me think about decrease. Okay, so blood pressure is also decreased here in both the things. Reduce cardiac output lowers arterial pressure. Okay, lowers arterial pressure. Okay, and heart rate is tachycardia always. Skin is similarly presentation is cold and clammy. Both are same due to peripheral vasoconstriction. Reduces skin perfusion. Okay, and urine output is oliguria both the case. Okay, both the case it is oliguria. So renal hypoperfusion causes oliguria, and pump failure primary problem, and volume loss is primary problem. This is the way you distinguish. So here you have to think about increase CBP and increase pulmonary capillary wedge pressure. Okay, this is cardiogenic shock, and opposite of cardiogenic shock is hypovolemic shock, which is decrease CBP and decrease PCWP. You have to know this shortcut. This is the way you can remember. Rest of all are similar actually. Clinical pearls you have to know is high wedge. High wedge means pulmonary capillary wedge pressure with low cardiac output is cardiogenic shock. Cardiogenic shock. Low wedge plus low cardiac output is hypovolemic shock. And similarly, low wedge plus high cardiac output is septic shock. You have to remember this. Okay. Cardiac output is low in both, but the main difference is PCWP increased in cardiogenic shock previously. This is increased in cardiogenic shock. Okay. And the hypovolemic is decreased in cardiogenic shock. You have to remember this. These are the most important. And in septic shock, I will be teaching upcoming session with septic shocks and SOFA criteria and other things I will be teaching. Low wedge pulmonary capillary pressure with high cardiac output is septic shock. Once again, I'm repeating. Management, I will be writing you. I will be mentioning you management. So management is very, very easy. So pharmacological presentation, you have to think about if hypotension persists despite adequate filling pressure, vasopressor such as norepinephrine for maintaining perfusion. Okay, perfusion. And next is, this is actually vasopressor. I will be writing vasopressor to maintain perfusion. And next is inotropic agency. Inotropic agency like dobutamine. Dobutamine improves myocardial contractility and increase cardiac output. So these medications should always be guided by careful hemodynamic monitoring. So management in case of revascularization in patient with myocardial infarction, PCI is used. PCI literally means percutaneous coronary intervention. Percutaneous coronary intervention is given in case of myocardial infarction, revascularization. This is revascularization. Okay, and you need to remember one thing is primary PCI is preferred strategy whenever available, while thrombolysis may be considered if PCI cannot be performed promptly. So alternative to PCI may be thrombolysis. Thrombolysis. Okay, restoring coronary blood flow improves myocardial function and survival. Okay, myocardial function and survival. You have to know this too, pharmacological. Mechanical circulatory support. When shocks persist despite medication, temporary mechanical support may be required, and device such as intra-aortic balloon pump may help maintain circulation while myocardium recovers until definitive treatment is possible. Okay. So prognosis, I want to say that cardiogenic shocks remains one of the deadliest cardiovascular emergency. Early diagnosis, prompt reperfusion appropriate, and hemodynamic support is needed, and timely mechanical assistant or the cornerstone, and successful management. Remember, the identify the cause quickly and restore the perfusion and support the falling heart. You have to question and answer. 75-year-old man is admitted in ICU. Okay, and following a laparotomy. And next is a pulmonary artery catheter shows pulmonary artery occlusion pressure, PAOP, high. Okay, this is pulmonary capillary wedge pressure, it may be also say. And next is cardiac output is low, and systemic vascular resistance is high. So shall we go back to previous slide? You can see one thing, that pulmonary wedge capillary is high and low cardiac output. You will be getting cardiogenic shock. Okay, cardiogenic shock. This is the easiest way to remember. So cardiogenic shock. And which of the following is not seen in hypovolemic shock? Huh? Hypovolemic shock. Decreased cardiac output, increased heart rate, and reduced LV filling pressure, reduced blood pressure, and reduced systemic vascular resistance. Go back to previous slide, we can see all the explanation, which is like systemic vascular resistance. Okay, systemic vascular resistance is not actually reduced, but it is increased with both the cardiogenic shock and hypovolemic shock. So this is the probable answer here. So not the reduced systemic vascular resistance, but it is increased. Rest of all the feature of hypovolemic shock as well as cardiogenic shock. So next is a 65-year-old man with a history of ischemic heart disease undergoes abdominal perineal resection. 2 days later, he develops cold and clammy extremity, tachycardia, which is 80 to 60 mercuric pressure, and temperature is normal. And most likely diagnosis they are asking, what could be the most likely diagnosis? Whether it is anaphylactic shock is not a thing, not in this. They should have given something like allergy related to this thing, or gloves presentation they should have given, no. Allergy to penicillin they should be given, no. So ultimately your answer is cardiogenic shock, because explanation, you have previous ischemic heart disease and cold peripheries and hypotension, and there is no fever. Okay, and these strongly suggest pump failure after myocardial infarction and worsening left ventricle dysfunction rather than the septic shock. Okay, you have to know these were the 3 questions totally. 3 questions from hypovolemic shock and 3 questions from cardiogenic shock. That's all for today's and exam tips. I'm actually closing. Thanks for watching the video. If you found this video helpful, and please like, share, and subscribe to Surgical Insights with Dr. Deepz. Let me know in the comment which surgery or which emergency medicine topic you would like to see the next. See you in next video. Aswidanya.